everybody. Thank you. Okay, thank you. We did have a pharmaceutical company support this event tonight, and I hope that everybody appreciates Celgene, okay, for, providing us the funding to do this. So I hope that you could all thank them as well. Thank you. But I want to introduce you to Dr. Michael Robers, correct? Wait, I got to read about you first. Okay, so Dr. Michael Robers has degrees in biochemistry. He graduated from Arizona State University and Loyola University in Chicago. He's done internal medicine. He's a neurologist. He's now neurology residency, and he's just doing more and more. And he's chief resident of Barrow Neurologic Institute. He's a member of the American Academy of Neurology. And let's just welcome Dr. Robers, and he could explain the rest about himself to you all. And he's working here at USC. And let's welcome this new guy. Thank you much.
Thank you very much. I want to thank you for the opportunity to speak with you tonight. Just a quick correction. I have finished my residency, so I am a neurologist. I'm completing training at USC to be a MS specialist. And so we'll talk a little bit about some disclosures right up front so we can do that. My research and training at USC is funded through the National MS Society. I'm employed by the University of Southern California. Tonight's talk is being funded by the MS Views and News, but none of those people made these slides. I made the slides and the talk. No outside entity was a part of that, so these represent my views. They do not represent the views of any of those organizations and should not be taken as such. So we have a lot of topics that could be discussed tonight, and so I tried to base it on some common questions that people often ask. And so some of the things that we're going to try to address tonight are, what is multiple sclerosis? Just a little overview. Who does MS affect? How does MS affect people? And then going into a little bit more detail of how do you recognize an MS relapse or flare, and what do we actually mean by that when we're the clinicians, the neurologists saying that, compared to maybe the common vernacular. And then what treatments exist for acute relapses, what treatments exist to prevent relapses, and why are those important compared to what you get when you have a relapse. And then what treatments exist for chronic symptoms, and how do we address those types of symptoms outside of the classic relapses and prevention that everyone wants to spend time talking about. And then along with that, what is a comprehensive healthcare team, and how does it affect the care of our patients? How should we plan for living with MS now and in the future? What are the impacts on family members and care partners? And what resources are available for those other members and caregivers as well? So it's a lot to get over. We're not going to go into great detail of those particular topics, but we're going to get a good overview of each of them, I believe. We're going to try to put a little fun things in here. Does anyone, go ahead and just raise your hand. You don't have to shout it out. Recognize what this is? I'll give you a hint. It's in a United States National Museum. Nobody's raising their hand. That's okay. It's a little obscure, but I am a nerd. So this is the chair that George Washington sat in while he was the president of the Congress writing the Constitution of the United States. Still in a National Museum there. And there's a great quote from Benjamin Franklin after they wrote the Constitution of the United States and they had already signed it and said they were going to send it out to the states for approval. He was talking to James Madison, and he said, "I have often looked at that behind the president without being able to tell whether it was rising or setting," speaking about the sun right here at the top of the chair. "But now I know that it is a rising sun," speaking of his optimism for the country that they was actually going to succeed. And I'd like to use that as an analogy for today's talk, because as we talk about some of the symptoms and some of the things we don't know about MS, it may feel like the sun is setting or even we're stuck in the middle of the night. But I hope that by the end of the talk, you'll agree with me that the sun is currently rising on MS care. So the first thing I wanted to talk about is, what is multiple sclerosis? And that's a very complicated question, and quite frankly, we don't know all the answers about it. But to briefly touch on what it is, looking over at the right side of the screen here, we have the blood stream is in red, and then the central nervous system is in green in cartoon format there. Now, the central nervous system is the brain and the spinal cord, and we have nerves that go all the way through that area that you can think of as wires. They have the middle metal part, which is an axon. It's the actual form of the signal sending, and then it's coated by a little fat layer called myelin. And what multiple sclerosis is traditionally understood to be is your immune system attacking that fat coating around the myelin in the central nervous system. There's also myelin on nerves outside of the central nervous system, but MS does not affect that. There's some debate as to how your immune system gets triggered for that, but it's commonly understood that it gets triggered somewhere outside of the central nervous system, in your bloodstream, in your gut or something there. It's triggered that says, hey, there's something going on. It now recognizes myelin, so the next time it gets into the central nervous system for monitoring, it now recognizes that myelin as something bad to the body, thinks it's something that might be a part of a disease or an attack, and it then attacks the immune system. Multiple aspects of our immune system are involved in the pathogenesis. It's not just one type of cell in the immune system. There's T cells and B cells, and then other cells, and they're all involved in multiple sclerosis. It's not just one type of cell. And so ultimately, that's the most that we understand about multiple sclerosis, those areas, that inflammatory disease. And so it's an autoimmune inflammatory disease that causes inflammation in that central nervous system. It predominantly affects the myelin, but it can affect that wire in the middle, that axon, which is causing more permanent damage. Your body can repair that myelin, but not as much the axons. There's unknown specific causes. We know that there's quite a few risk factors for multiple sclerosis, which include genetics, that includes vitamin D levels, that includes where you live, smoking, and possible viral factors. Some people believe exposure to the Epstein-Barr virus is related, and there are higher levels of that in people who develop multiple sclerosis. But as far as one individual person who has multiple sclerosis, what triggered it for them, we don't know. These are all just numbers and groups of people. So that's a little nitty-gritty of what multiple sclerosis is, but what do we really care about as patients and family members and clinicians is the symptoms. And so this is a little map of the symptoms that result from multiple sclerosis. And we now understand, if you look at these bars right there, those are events of inflammation in the central nervous system. And that dotted line that comes across here represents how much inflammation needs to happen for you to develop symptoms. And so we now recognize that early on in the disease, there are events that we don't even know. We don't see it. Nobody ever has a symptom from it. And sometimes those might be found just because somebody receives an MRI for a reason completely unrelated to multiple sclerosis. Then at some point, they have enough inflammation that they receive an attack, and now they have what we call clinically isolated syndrome, which means that they've had one attack, but to be diagnosed with multiple sclerosis, you have to have multiple, in the word, and sclerosis, which means plaques or attack scars in the brain. And so oftentimes when someone first has that first attack, your neurologist or your doctor may be suspicious of multiple sclerosis, but might say, we can't officially diagnose multiple sclerosis yet, but we think that's what it looks like. And then there's criteria to use MRI to try to diagnose it more specifically. Then, once somebody has had multiple attacks or evidence of that on MRIs that we can confirm the diagnosis, they have multiple sclerosis. Oftentimes, the most common form is relapsing remitting multiple sclerosis, which means that you have these acute events, and acute meaning quick onset, that events of new inflammation, new symptoms, new disability that oftentimes then remit or get better over time, and that can go on for years. Then we know that in addition to the inflammatory part that I talked about in the last slide and this slide, there is also a degenerative process associated with multiple sclerosis here. That underneath all that inflammation, there's more damage that occurs to the brain and the spinal cord that can cause somebody to continuously have more symptoms without having any new lesions on MRI, without having a quick, sudden change. And so that's what we call progressive MS, and that can be split up into secondary progressive MS, over here on the far right, with somebody who's already had relapsing remitting multiple sclerosis and then transfers into a progressive form. Or a small subset of people just have that from the beginning, and they really never have these relapses that we talk about here, but just gradually get worse the whole time, and that's primary progressive multiple sclerosis. So this slide should confirm to you that it's a complicated disease. It's much more than just inflammatory attacks. Silent attacks occur before or in between clinical attacks that you recognize and know and go to your doctor about. And there's still a poorly understood portion of the disease that is this underlying degenerative process that we don't know exactly how to stop or exactly what causes it. There's multiple types of what we call clinical phenotypes, or how you present with symptoms, whether it's the clinically isolated syndrome, the relapsing and remitting, the secondary progressive, or the primary progressive, and it's still debated among doctors as to whether those are all actually the same disease or whether those will eventually be split up into multiple disease entities. It is a chronic disease that will affect the patients their entire life, which I think is mapped out well in this slide as well, so it's important to understand that. Who does MS affect? Well, it affects over 400,000 people in the United States and 2.3 million people worldwide, so it's quite a bit. It's 2 to 3 times more common in women, but it does occur frequently in men, and we all understand that now. It occurs most commonly in white populations, but we now understand it affects almost every ethnic population or race. So the days of saying, oh, you're not white, so you don't have multiple sclerosis are gone. Don't let anyone say that. It typically is diagnosed between the ages of 20 and 50 in these young adults who are otherwise healthy, but it is well understood now that it can occur in childhood. It does not have to be adults, and we diagnose people routinely well over the age of 50. So while the numbers give you these trends, it can have outliers. As you can see on the map, there is a gradient. The farther away from the equator you get, the more common it is, especially more common in the United States, Canada, the Scandinavian countries, and then when you go south, more common in Australia and Argentina. Is the farther south or the farther north you get is more common. But I think that map shows you quite well, and these statements show you quite well, it affects everyone. So while there's numbers that we use to know one person's more likely or less likely, it's never that it can't affect you. It can affect everyone. So now that we've said that it's a lifelong disease that is not well understood, that can affect everyone and can cause significant disability, you might feel like the sun is setting. And so we're going to move a little bit farther into some more information. How does MS affect people? So no two people are the same. It's important to understand that it's good to go to support groups, good to talk to your friends who also have multiple sclerosis or also are caring for someone with multiple sclerosis, but their symptoms or their family member's symptoms may not be the same as your symptoms or your family member's symptoms. And that doesn't mean that one person doesn't have MS and one person does, or vice versa. These symptoms can be very different for every individual. Some common presenting symptoms include optic neuritis, which is inflammation of the optic nerve right behind the eye, myelitis, which is inflammation of the spinal cord, numbness, weakness, double vision. But it can affect any system that uses the central nervous system for control. So anything that your brain or spinal cord is controlling, it can affect. And so you can look at the figure here on the right, and everything it points out: fatigue, cognitive impairment, depression, unstable moods, even if you don't feel depressed, uncontrollable laughing or crying, visual changes, abnormal eye movements, loss of sight, double vision, changes in your speech, changes in your swallowing, weakness, muscle spasms, stiffness. Ataxia means inability to control your fine movements, inability to hold things, pick up things that you're aiming for. It can cause both a loss of sensation and positive sensations of paresthesias, which is just weird tingling sensations that people feel, or actual pain. It can cause bowel bowel difficulties, it can cause urinary difficulties, it can cause sexual difficulties. So it affects almost every system in the body. There is significant risk of long-term disability. In the pre-treatment era, meaning before medications existed to try to change this, a majority of patients were unable to walk after 25 years with the disease. So we know if it's not treated, this is a disease that will likely cause significant disability in this population. People who have multiple sclerosis are 2 to 3 times more likely to be hospitalized than the general population, and they use twice the emergency services than the general population in the United States. They have a reduced ability to work, perform activities of independence, like driving, cooking, walking sometimes, as we discussed, and there may be a small effect on life expectancy as well. Most people with multiple sclerosis live a full, happy, healthy life, but there certainly can be a small effect on life expectancy. So now it may feel like we're in the middle of the night and wandering through the desert, which I promise that is actually a picture of the desert, not quite coming out on the screen, but it's the night in the desert. But I promise it will hopefully get better. Patients can take control of their care, and that's the message that we're going to be going throughout. Multiple sclerosis doesn't have to control the patients can help control their disease. How can they do this? Well, they can know and use acute therapies, meaning therapies for those attacks that have new symptoms, changes in their disease. They can use long-term disease-modifying therapies, which are diseases that can actually change the course of the disease long-term. They can use medications or non-medication management for their symptoms so that they can improve their quality of life. They can use comprehensive care teams to make sure that everybody knows what is important to them and what is needed to improve their care, so everyone's talking together. There's lots of community support groups and support systems through independent organizations, and there's research opportunities always going on that people can participate in as well. So recognizing an acute relapse. This is one of the most important things for a patient to be able to know themselves or a family member to be able to know of their loved one, because oftentimes your next appointment with me is in 3 months, 6 months, maybe a year if you've been stable for a while. If something changes in between those, the only person who can tell me that is you. So what do we mean when we're having an acute relapse? Well, we mean new or worsening symptoms. If these are symptoms that have been bothering you for 4 years, it's something we should address, but it's something we'll address in a later slide. It is not an acute relapse. It is typically a subacute onset, and what I mean by that is that it is not all of a sudden. It's not 1 minute you have nothing and 1 minute you have something severe. That's more common in things like stroke, and people who are aging with multiple sclerosis can still have those and other diseases. But it's also not chronic. It's not something that comes on slowly over the course of weeks to months. This is something that usually comes on over the course of hours or a day or two. It lasts at least 24 hours. Some people say 48 hours, but at least 24 hours. And so that means symptoms that come and go over the course of minutes to hours, again, still might be something to address, but may give us a different diagnosis. Headaches, vision changes that come on, last a couple of hours, maybe migraine. Still very common disease, even if somebody also has multiple sclerosis. Maybe a pain in the face that comes on over minutes and goes away. Maybe trigeminal neuralgia, very common in multiple sclerosis. So there's other things that we can diagnose, but it may not be directly related to a multiple sclerosis attack. And it's attributable to the central nervous system. This is one you may not be able to answer yourself, but this is why it's important to call your care team and notify them that you're having new symptoms so that they can discuss it with you, maybe fit you in and examine you, and so that you can actually figure out if it is attributable to the central nervous system. And it does not have an ongoing infection. That means some people have heard the phrase pseudo-relapse, which is commonly used. when people have scars from multiple sclerosis, their body learns to work around those scars. But when you get sick, when you have a urinary tract infection, when you have the cold, when you have the flu, your body is now using a lot more energy to fight that off, and now it can't really do all the workarounds for all those scars. And so some of your old symptoms may reappear in the setting of the sickness and instead of the infection. And it's important to distinguish that, because we don't want to give you steroids when you have an infection, because that tampers down your immune system that you need to fight off the infection. So the treatment for a pseudo-relapse with all these same symptoms caused by an infection is to treat the infection, not to treat a relapse. There are some classic syndromes of acute relapses that are important to know that some of you may already know. Optic neuritis, which I already used, is inflammation of the optic nerve, the nerve that connects the eyeball to the brain. That usually presents as a painful eye, one eye, especially with movement, and vision loss in that same eye. Especially you might notice that colors look duller or grayer. What we call partial myelitis, again, inflammation of the spinal cord is myelitis. And when we mean partial, it means it doesn't involve all three aspects of the spinal cord. And so one or two of the next symptoms: bowel or bladder changes, weakness or numbness. Oftentimes, you might notice that the numbness cuts off at a level. So it's like everything below my belly button feels different, isn't working as well. That is a sign that it's involving your spinal cord. And that's a reason to definitely talk to your doctor. This is a big mouthful, intranuclear ophthalmoplegia, or INO. You don't necessarily have to use those words, but it's important to recognize that double vision, not just vision loss of the optic neuritis that lots of people know, but double vision can be directly due to multiple sclerosis. Often, especially when you're looking in one direction, people looking at you may say that your eyes are making funny movements, something we call nystagmus, but you may not know that, and that's okay. But double vision is an important symptom, not just vision loss. Brainstem syndromes. You can have attacks in the lower part of your brain and where some of the signals have already crossed, and that can give you what we call a crossed brain syndrome, where one side of your face is affected and the other side of your body is affected. And so that's a common symptom where you might say, oh, I have numbness in the left side of my face and the right side of my body, and we think, oh, it's all usually one side. Strokes the right side of your body or the left side of your body. It's all one side. That's what it's supposed to be. But you can actually get it where it's crossed. And then you can have new onset, very poor balance, or unable to reach and grab things, trying to reach, very difficult for items, dropping things from your hands, feeling a sense of vertigo, the room is spinning, or like you're on a boat. Those things coming on again over those minutes to hours, lasting more than 24 hours. You should think you're not drunk, you're not just off balance and clumsy. This could be because of multiple sclerosis. These are all reasons to call your doctor's office, tell them you're having new symptoms. Why should we call the doctor? Why should we tell them about this? Because we can do something about them. First, contact your doctor's office. Let them help you confirm that this is, in fact, a MS relapse. And if it is, the most common thing that we treat it with is steroids, usually methylprednisolone, usually high dose. It's been studied well that just giving low dose of steroids, something that used to be done, does not work as well as the high dose of steroids. We usually give it for between 3 and 5 days, depending on what the symptoms are and how you respond to them. IV is standard, but if cost is an issue or needles are an issue and having that is a problem, you can use pills. You can use oral steroids still in the high dose. The problem is they don't make them in 1,000 milligram pills. They would probably be the size of your arm. So you would be taking like 30 pills a day. But it can be done. And so it's important to talk to your provider about what the best way to do that is to meet your needs so that you can be treated in the most comfortable way possible. Oftentimes, depending on your insurance, these can be given at home. You don't have to be stuck in the hospital. So don't avoid talking to the doctor just because you don't want to be sent to the hospital. Oftentimes, we can help you get this at home. Why do we do this? We know that it improves the speed of recovery. So if you were going to take a month to get better, this will get you better in weeks. We do also know it does not affect the long-term prognosis, so it does not prevent future attacks, and it doesn't actually make you get better than you would have. It just makes you get better faster. There are quite a few side effects to steroids, including insomnia, hyperglycemia, so any diabetics in the room need to be aware of that. You may need to adjust medication with your doctor's approval in order to keep your diabetes under control while you're receiving steroids. It can cause some agitation, anxiety, very rare, but it can cause hallucinations. And so that's well known, and people should tell your doctor if you're having side effects so that they can help mitigate that. If people have had very bad reactions to steroids, there are some other options. The most common of which is corticotropin called Acthar gel. It's an injection, has to be kept in your refrigerator, is quite expensive, so fighting with insurances can be a part of it. But while it lists a lot of the same side effects because it stimulates your own body's steroid production, so essentially it's working the same way long term, a lot of people just notice it does seem to have a little bit less side effects and is a little bit more tolerable if you're somebody who didn't do well with steroids. For very severe attacks, you've had your steroids, you're still not any better, you're not able to walk because of a severe inflammation in your spinal cord. There are other things. I'm not going to go into great detail of the name of that, but just know you might need to be hospitalized at that point, but there are still other options if you don't get better after steroids, so keep talking to us. So we're about to get to the sunrise now. We have some acute treatments, but there's even more good news about the future of multiple sclerosis, and we'll talk about that now. So what treatments exist to prevent relapses? When I was born, the answer was nothing. And the classic joke to make fun of neurologists among doctors is diagnose and adios, because there was nothing that we could do for anyone. That's not true anymore. There are over a dozen approved medications for multiple sclerosis. Admittedly, most of them are for relapsing remitting multiple sclerosis, but there are new medications approved for progressive multiple sclerosis as well. Won't go into great detail about all of these medications because this is an individualized discussion that you should have with your doctor about what medications you should be on, but a couple of highlights that people may know recently or may not know about what's coming up in the future. Ocrelizumab was the first medication approved by the FDA for primary progressive MS just in 2017, so it's a new medication. It's also approved for relapsing remitting MS, so people may be on it for that reason as well. Why did it take so long? It's a little bit of a political fight. You might see rituximab, phase 2 trials in 2008, showed some promising features but didn't reach statistical significance for primary progressive. Its patent was about to run out, so the drug company said, oh, let's not get that approved where we won't make a lot of money. And they developed a whole new drug, so all the way in 2017, after 2008, was a new drug. It's important to note that how it is helping primary progressive MS is still in those patients who have inflammation that we can see on MRI. It is not affecting that underlying degenerative process that I was talking about. So it's not the end-all. We still need more research. We still need more information about progressive MS, but it's a step in the right direction. For secondary progressive MS, there is one medication that's been approved since 2000, mitoxantrone. It is actually chemotherapy, has significant long-term side effects, including the heart and some cancer risks, so it's not for everyone, but it exists. Coming probably next year is a medication called siponimod. The research is already published. It has significant results. It shows that it reduces the disability in patients with secondary progressive multiple sclerosis. It's a cousin of a medication already out called fingolimod. So we have an idea about the safety profile already, and because of some slight differences in the pharmacology that I won't go into, we actually think it may be slightly safer in its heart side effects than even fingolimod. So that may be news. Look for that coming out. Hopefully FDA approval sometime in the next year. And then for progressive MS, actually both primary and secondary, we're looking right here. Some people may have heard through rumors something called high-dose biotin. Biotin's a vitamin. You can buy it at the store. It's for hair and nails at the doses that they sell you at the store. Very high-dose medications, like orders of magnitude higher dose, having to get it through a specialty pharmacy. It has been shown to help patients with progressive MS in one French study. Was randomized, placebo-controlled, meaning that they split everyone into groups who did or didn't get the medication. Nobody knew who was in what group, and the group that got the medication did better. That one study was not enough to receive FDA approval in the United States, so it is an off-label medication currently, but they are doing a trial in the United States that the results are not back yet. That trial has completed recruitment, but they're continuing to follow the patients. So hopefully next year we'll have the results of that trial, and then it takes another year to actually apply for FDA approval. But if everything goes well, maybe 2020-ish, there might be that choice. So those are things to keep in mind for the future and talk to your doctor about as well. Medications, as all of you probably know, can be split up into different types of therapies as well. Injectable medications, about a 30% relapse rate. Oral medications can get up to 50 or 60% reduction in relapse rate. Then there's the infusion medications, which range from every month to every 6 months to alemtuzumab. You actually receive it over the course of 2 years and then maybe don't receive anything for 5 or years or longer. All of those medications have different side effects. The point of showing this slide is not to advertise one medication over another. Again, that's a very individualized discussion that you should not do just because of some guy standing on a stage or a drug rep who puts an ad out on TV. It should be because you talk to your doctor about what's right for you. But know that if one type of medication isn't working for you, talk to your doctor, talk to your care team. There are other options. We can make something that works for your life. So why is it important to take these medications and keep taking them? One of the most common complaints that we get after somebody goes through the whole process of getting insurance approval, worrying about the risks, reading the 1.5 mile long risk of potential side effects and deciding to put their body exposed to that medication, and then they come back and say, I don't feel any better. It's not supposed to make you feel better. That's important to remember. Expectations are important to realize. These are proven to prevent you from getting worse in the future. So in patients with that clinically isolated syndrome, had one attack, maybe don't quite meet diagnostic criteria for multiple sclerosis, these medications are proven to extend the time it takes before you become definitive multiple sclerosis. They're proven to reduce relapse rates in people with relapsing remitting multiple sclerosis. They're proven to reduce the number of lesions on your MRI over time. Again, that doesn't get rid of lesions that are already there. It's just that when you split people into 2 groups, the people who don't receive the medication get more new lesions on MRI compared to those on the medication. And it's proven, this is the most important one, proven to reduce disability progression. It's proven to reduce the amount of extra disability you get after you start the medication. So it won't make you feel better, but in 10 or 20 years, it makes a difference as to whether you were on a medication or not, and that's important to remember. Those last 2 slides are what doctors and patients spend a bulk of their time talking about, and that's really unfortunate. They can be done fairly quickly at 1 visit, 2 visits. If you have a new lesion, a new relapse, you might need to change medications, but once you have a medication that's working for you, that you're stable, it's important to do this, and this is overlooked so much in clinics, and we need to work more on exposing this. What do we do for treatments of chronic symptoms? Again, they may not be what we call an acute relapse, but that doesn't mean they're not important to treat. As you can see, almost all of those medications, it's just like that picture of the man a couple slides before. It can affect every symptom, every system of your body, but we have treatments for almost all of these as well. I'm not going to go through all of these, but a couple to point out. The oxybutynin is probably the most common medication we use for urinary frequency. So people are having to run to the bathroom. It's not just about having to go to the bathroom a lot. It's about then hurts your sleep because you're getting up 4 times at night. Now you're more fatigued during the day. Now you're more weak because you're fatigued and falling asleep. But that is a medication that can affect your cognition. So if you have MS fog, may not be the best medication for you, or you may try it and then see whether it causes problems. And if it does, there is another medication that is through a different mechanism of action that doesn't cause that as much, called Myrbetriq. Honestly, I can't pronounce the generic name, and they do that on purpose. They want us using the name brand. So it's all it's all the tricks. We know that they do it there. Emotional changes. We have medications, even if you don't feel depressed, but you're having uncontrollable expression of moods, that can be something called pseudobulbar affect. That can be treated. If it's actually depression, that can be treated. Fatigue has multiple medications that can be treated. And then I want to just highlight sexual difficulties. Again, that's something that people don't like talking about, but bring it up because there are treatments available for it. And then spasticity is one of the biggest things that we see chronically that affects your ability to be able to walk, be able to do daily activities because your muscles and your limbs are so stiff that you can't move them very well. There's lots of different medications. We typically use baclofen first. If that doesn't work for you, we have another oral medicine called tizanidine. And then if you just have one area in your muscles, like your legs are really tight, or just one area in your arm, Botox, it's not just for wrinkles anymore. The symptoms, that's just a locally acting medication. So if you're getting side effects from all the pills, but it's really just one section that bothers you, you can get that. Something that's often not talked about in generic neurology clinics, but in specialty clinics is important use, is the actual interthecal baclofen. It's a big word. It means it is a pump that gets implanted under your skin and a tube that goes directly into your spine. And it's at the bottom of your back, not in your spinal cord, but underneath it. Once the procedure's done, you don't feel it. The point of that is the same medication that you take in a pill called baclofen. It's muscle relaxant, but they can do it at much smaller doses directly into your fluid that bathes your brain and spinal cord, which means that you don't get the same side effects of all the drowsiness that you get with the oral baclofen. And for certain people with spasticity all over that is affecting their ability, that can be a good option for people. And it's not just for one type of group of individuals. People who are already using wheelchairs sometimes can help you make sure that you're avoiding infections and sitting properly in the wheelchair so that you're not getting bed sores and things like that. Again, none of these medications are right for everybody. Don't do it just because I'm saying it on a stage. Talk to your individual doctor. So we've gone over a lot of medicines, but a lot of people don't like taking lots of medicines. So what can we do besides medications? We're going to talk briefly about complementary medicine and non-FDA approved interventions. So none of these are clinically evaluated in the same way that the medications are, where they have to be proven to be safe and efficacious by the FDA. These are all off-label treatments. The first one is evidence-based as much as any medication out there almost, and that's vitamin D. We know that people with lower vitamin D levels are at higher risk of developing multiple sclerosis, and we know that multiple sclerosis makes it more common for you to have vitamin D deficiency. So you can check levels, and actually we know that people with multiple sclerosis tend to have lower levels. We believe that giving vitamin D supplementation does actually benefit patients for a couple of reasons. Vitamin D deficiency can actually cause fatigue and things like that. So if you are low, supplementing that might help with some of those secondary symptoms. But looking backwards at some of the trials, so not the same way that the FDA requires you to do it, looking forwards, not the main goal of the studies, but looking backwards at some of the research trials of the medications for treating multiple sclerosis, they found that people who were taking vitamin D tended to do better than people who weren't taking vitamin D in addition to the medication that they were on. It's not definitive, not something that's going to be a prescription written by the FDA, but we're pretty confident that vitamin D does help people and it has very low risk. And again, levels can be checked, so if you're not sure you want to check on that, you can just see where your level is, and if you're normal, you don't necessarily have to, but if you're low, it might be a good idea. Exercise, I'm not going to go into a great deal of detail here because I'm not going to step on any toes of our next speaker, but just to say, studies in multiple sclerosis have demonstrated better cardiovascular fitness, improved strength, better bladder and bowel function, less fatigue, less depression, increased participation in social activities, all independent of the medications we give you. Everyone should be doing some level of exercise according to their abilities. It really is a good thing. And it's good for health outside of multiple sclerosis as well. So it's a good thing to do. And we don't necessarily mean you have to be running a marathon. We get that not everyone's going to do that. I'm not going to do that. But everyone has some level of activity that they can do to fit with them. And then maintaining healthy habits. So we know that smoking is a clear risk factor, both for multiple sclerosis and for disability progression. If you smoke, quit when you walk out the door tonight. If you don't smoke, don't start. And then other things like obesity, hyperlipidemia, diabetes, all have some evidence, some research that says maybe they're associated with MS in a way of causing more disability. That's not settled fact necessarily, but some research exists. And so while we don't give a specific goal for any of those things, we say maintaining a healthy lifestyle is going to be good for you whether you have multiple sclerosis or not, and it's probably good for you if you have multiple sclerosis. If you have other medical diseases, getting them under control probably will help us get your multiple sclerosis under control as well. So it's important to see not only a neurologist, but a primary care doctor or other specialist that you may need. And that will get us into another topic after this slide. But first, we're going to talk about complementary medicines that are not FDA approved. These have no large studies, so these have less research than the last slide even. Just being upfront. Acupuncture. It's used for pain, mood, and spasticity. I have not seen any research that convinces me it works, but I have seen research that convinces me it's not going to do you any harm. So if you're somebody who's inclined to do that, I'm not going to tell you not to, but I haven't seen any proof that it does work. But some people do use it. Marijuana, a big topic in California, a lot of states now. This actually has some pretty decent research for it. Not great trials like the medications we use regularly, but some medium-sized studies have shown likely, but not in a definitive way, that it benefits spasticity and pain. And so spasticity is the stiffness, and pain is pain. When I say it's not definitive, it means when they went to the doctor's office, there was no objective measure that we could say, oh yes, we can tell your spasticity is better. But when we did surveys and just asked people who didn't know what they were receiving, does this help you? They said yes. We don't believe it actually affects the disease course. So this is not to replace your MS medications, but it is something that you can consider for specific symptoms if need be. Some small studies have shown that there are cognitive deficits with THC, which is the active ingredient of marijuana that makes you high. It's kind of a no-brainer. Being high affects your mental status. I think we all know that. But CBD is probably what is actually helping the spasticity. So if you're going to use a marijuana derivative, it's probably better to use lower THC, higher CBD. Again, I'm not quoting evidence. I'm not quoting advice. I'm not telling you to use marijuana. I'm just giving some generic advice. The good news about marijuana, for years and years, it was what we call Category 1 medication, meaning that it was classified by the Drug Enforcement Agency as the same as heroin and crack cocaine, and that it had absolutely PCP, absolutely no medical use whatsoever, and therefore you can't even do research on it. The FDA approved a medication based on CBD and marijuana for epilepsy, refractory epilepsy, this year, and as part of that they reduced the level from level 1 to level 4, and what that means for you is that they're going to do more research in the future. And so in 10 years, instead of these vague statements and these corner pot shops, CBD-derived medications are going to be prescribed through regular pharmacies for things that we know it works for, and it won't be prescribed for things that we don't know it works for. So that's 10 years, 20 years down the road, it's going to have more research, but right now it's this vague answer. Some people think it helps. Diet. A lot of interest in diet overall. There's no specific diet that's been accepted or proven to change the course of multiple sclerosis. It certainly cannot overtake your courses of medications, but some animal studies indicate that maybe high-salt diets are bad. High-salt diets are bad for hypertension and stroke as well, so it's not really going that far out on a limb. And certainly there's lots of evidence in general health that a healthy diet, lots of fruits and vegetables, things like that, is good for your health. So if you eat a diet that is good for your health, that's probably the way to go. Well, any one person's specific diet cookbook is not proven like a medication to help, but eating healthy is a good thing for you. What's a comprehensive healthcare team? So we talked about needing to talk about your primary care doctor to take care of your diabetes, your hypertension, your other things. We talked about exercise. We talked about diet. We talked about depression. We talked about urinary control, spasticity. I don't do all that. So how do we actually get you to control all of these things? Well, we need a whole team of people talking about you together. And so specialists that can participate in MS care, PT, OT, orthotic specialists, social workers, pharmacists, nurses, counselors, psychiatrists, urologists, lots more, even for younger people, OBGYNs, pregnancies, now common in multiple sclerosis. You can have a family, you can have a very healthy future, but we want all these specialists talking to each other. So my definition of a comprehensive MS center is a center is a neurological clinic. Your neurologist as the MS center should be the captain of the team that's specializing in care of multiple sclerosis and coordinating care between multiple specialties, both medical specialties and non-medical specialties, to provide efficient and appropriate care for all of the patient's related needs. So that's choosing a disease-modifying therapy, treating acute relapses, but then also treating all those symptoms. And if you need to see a urologist, if you need to see a psychiatrist for your depression or anxiety, if you need to see physical therapy or orthopedic or occupational therapy to help with that, you need to do that. Pain management or rehab does the baclofen pump evaluations. All those people should be talking to each other about you. And some centers have at least some of those people all in the same building. At the place that I work at USC, we actually have a neuropharmacologist who is there at clinic with us to answer questions about side effects, about dosing. I walked in a room today with a physical therapy resident that was able to help readdress some walker needs and things like that right in the same room. We have a specialized clinic occasionally that we actually work with ophthalmologists who can review the eyes at the same time depending on what kind of disease course you have. And those can all happen in the same room. But we don't work with everybody, so we're working over the phone or through computer systems to communicate with psychiatrists, urologists, other specialists like that. And so it can be in the same room, but it doesn't have to be. If your private practice neurologist is just a neurologist, as long as that neurologist is communicating regularly and can tell you, yeah, your primary care doctor told me that you needed to be on this and this is good. I spoke with your urologist and I like that the plan is this. Those are good things. If your neurologist is not communicating great with other specialists, you can help encourage that. You can take control. This isn't just the doctors treating you and the disease controlling you. You can take control of it. So bring in the notes from your other doctors and say, hey, this is what my other doctor said. Can you read this? Tell me what you think about it. Hey, I was prescribed this new medication. I want to make sure that it's on your list. I got an MRI at an outside facility because I was there for something else. I brought the CD, not just the radiologist report. Bring the CD. So doing that can really trigger the doctors to talk about what your special needs are. Which brings us to how should you discuss the symptom management and coordinated care with your doctor? Be proactive. Come talk to us. Know that you are not alone and you do not need to feel embarrassed about any of the symptoms that you're having. I talk to people about bowel incontinence. I talk to people about urinary incontinence. I talk to people about their sexual function. It's not something that I'm bothered by. It's not something that I'm embarrassed by, and neither should you. The only way that we can address these symptoms are if we can discuss them openly and freely. Make a list of your symptoms or questions that you have before you get to the doctor's office, because it can affect a lot of symptoms as we talked about, and you may have multiple you want to talk about, and then you get stuck in traffic in the rain and you're ticked off and the doctor's running an hour and a half late, and now you can't remember anything. So make a list. Just read them off in the clinic. Ask questions. Don't let somebody just walk out the door without having let you had your say. If there's many symptoms that need to be addressed and it's too much time for one visit, that's okay. Make multiple visits. It's okay to have one visit designated to, we're going to discuss my medication this clinic, but then I have these symptoms that have been going on for a while. They don't need to be addressed today, but I'd like to come back in a week or two or in a month instead of 6 months so that we can talk just about my symptoms and just about my chronic things. That's okay. Have multiple visits. Sign up for remote communications. Almost every doctor's office is part of the federal regulations that require us to use electronic medical records now, have what they call meaningful use, which means that in order to get the highest level of reimbursement, you have to be doing certain things, and one of those things is often an electronic communication system. So that's a quote-unquote patient portal where you can actually email your doctor. Places that don't have that will at least have a card or a phone number that you can talk to a nurse. Sign up for those things, because in between appointments, if something comes up, if you have a question, send an email. They can get back to you. They can call you. Leave a message. We don't always have to be face-to-face in order to address a symptom or address a question that you have. And that means that you don't have to take time off of work, or you don't have to take time off of being a part of your life either. You can still get the care that you need remotely. Ask your providers to talk to each other, but also talk to each other about what each provider is telling you, and that's a good thing. And that's a good way to make sure that you understand everything. It is repeating. So you repeat what somebody told you. It makes sense to the doctor. They repeat back, and we know that everybody's on the same page. When doctors are working in hospitals and handing off the list of patients from one day to the next, we say everything out loud, and then the next person says it back. And if there's anything wrong when they say it back, we go over the whole thing again to make sure we're saying the right information. So repeat things that you've heard. And then utilize community resources. There's things called MS Navigators, sponsored through the National MS Society, that are over the phone, can hook you up to local resources. There's resources online like MS Views and News that you can get educated information just from online. A lot of clinics have a social worker there that can hook you up to specific resources that you need, whether it's helping with work information or just other local support groups, wanting to get in touch with somebody who's on the same medication that you. Hey, I don't know if I really want to start this medication. Can I talk to someone? That oftentimes people have signed up with either their clinic or the drug company and say, hey, if another patient has questions about this medication, I'll talk to them. So utilize those resources that are out there. There's a lot more than just going to your doctor's appointment. So now that we know there's lots of treatments that we have, there's lots of symptoms that we have, but there's lots that we can do about it, and we have this coordinated care, it's time to plan for the future about how we're going to deal with the disease long term, because we know it's a chronic disease. There's nothing that any individual with multiple sclerosis is not allowed to do because of multiple sclerosis. So just like being a kid, you can do anything you want to do to a degree. Because MS affects everybody differently, while they do have successful careers, they have children, they raise families, live normal, independent lives, there are some activities that individuals may not be able to do based on their individual situation. Every person with MS is different, and it's important to be honest about your personal limitations, whether that's physical or emotional or just from fatigue and things like that. When you have a goal of something you want to do, discuss it with people. Talk to your family. Talk to the people who are helping you care for yourself. Talk to your doctors about, hey, this is something that's important to me. I want to be able to work. I want to be able to walk. I want to be able to be independent and go out to restaurants, even if that means using a walker or a wheelchair. But I want to be able to do X, Y, and Z. Those are what's important in my life, what gives me happiness. And then talk your limitations. I really like going out to restaurants and eating 5-star meals, but I can't do it. Why? Well, I can't do it because I can't afford it. Well, the doctor's not going to help me with that, but somebody may not be able to do it because it's just too far from all the parking lots to your favorite restaurant. Well, we can work on that, whether it's getting a motorized scooter or a cane or a walker or getting a handicap license plaque so you can park closer. There's things we can do about that bridge. So talk not just about your goals, but hey, this is what I want to do, and this is why I'm not doing it right now, so that we can discuss about how to overcome those barriers. Treating MS is all about overcoming the barriers. Be honest about your limitations, and please be open to adaptive technologies, adaptive facilities. If you say, I can't go to my favorite restaurant because I have to park too far away, okay, we'll get you a handicap sticker. I don't want to use a handicap sticker. I don't know what to do. So be honest about what the help you're going to need, and be open to the adaptive technologies. A lot of people really hate using canes, admitting that they need a little help. But you know what? If it helps you walk 3/4 of a mile instead of a block, because now you're not going to fall and now you're not going to feel afraid, it's good for your quality of life. If you need, you're tired of pushing a wheelchair with your hands, push it with getting a motorized wheelchair. And then when you're talking about this, don't just talk about the limitations that you have now. Talk about, what are you going to be in a year? What do you need now? You fall once a month now, but your significant other that helps you get up has a bad back, isn't doing really well. Maybe in 6 months or a year, you're going to need a lift or something that's going to help you get up. And it takes time to get insurance approval for that. It takes time to get insurance approval for orthotics. They have to get fit. They have to get put on wheelchairs. Take time. So talk to us about that early. What are you going to need in 6 months? What are you going to need in a year? Not just what you need today. Caregivers age 2, bad backs, bad knees. So there's assistive devices that help more than just, if your only plan of being able to get out of the bed in the morning is that your spouse loves you, that's not a plan. It takes time to get new equipment, which we already talked about. MS, and we talked a lot about how it affects the patients and what we can do for them, but MS affects family members and caregivers as well. So we want to talk briefly about that. The first thing we do have to admit is that if you are a family member of someone with multiple sclerosis, you have a higher risk of developing multiple sclerosis more than I do. We said that at 400,000 people in the United States have multiple sclerosis, it's about a 0.1% chance of developing multiple sclerosis for the general population. If you have a brother or sister or parent with multiple sclerosis, you have about 2.5 to 5% chance. Good news is that means that 95% chance you stay perfectly normal, but it is more than general population. If you have an identical twin with multiple sclerosis, your chance is 25%, 1 in 4. There is no proven therapy to prevent the development of MS in these people. We don't have that research. Might be research in the future that people can participate in. There's lots of times when researchers are very interested in discussing siblings and also especially twins. There's often twin studies going on. But staying healthy overall, again, is a great idea to help you with all your medical needs. Some people, again, there is evidence that people who have low vitamin D levels have a higher risk of developing multiple sclerosis. I'm not telling you to do this. I have no evidence to prove that it's a good idea. But some people choose to take vitamin D or have their levels checked to see if they're vitamin D deficient if they have a sibling with multiple sclerosis. And then if you're a family member, you're not worried about your own care of multiple sclerosis, but you are worried about caring for the other person, that affects your own health because you're worrying about someone else more than worrying about yourself. You're worrying about them most of the time. When you go to work, you're worried about, have they fallen at home and they're just laying on the floor until they're ready for me to come home. And that can take a toll on yourself. So it's important. If you don't care for yourself, you can't care for your loved ones. So it's important to see your doctor, make sure your diseases are under control, and also take care of your own emotional health. There are lots of resources, both for patients and for family members, through the National MS Society. I'm getting paid by them, so don't worry about the plug too much. MS, I got this backwards, sorry. MS Views and News, and there's their website. Again, they're funding this talk, so don't worry about that plug too much, but those are great organizations that do give you good information. Your neurology clinic may have social workers or specialists that help with extra resources beyond what the doctor is doing for you. Disability lawyers. Insert lawyer joke here. But for this one instance, it may be important. If you depend on your disability for income, and that application means whether you're going to be able to stay in your house, whether you're going to be able to put food on the table, it's a complicated process. Most people get denied at least the first time. If you have the ability to hire a lawyer for your disability, it's probably a good idea. Local support groups, we mentioned quite a few of them already. It varies from place to place as to what support groups are available. Lots of them are peer-to-peer support groups. Some of them are with counselors or things like that. But it's important to get tapped into those communities' resources. You can really benefit quite a bit from those local resources. So with that, I'd like to thank you for listening to me drone on for so long and take any questions.
Awesome. Let's give Doctor a round of applause. So I need to see a show of hands of who has questions, all right? And please, please, everybody, remember, I need to get to you before you ask a question. So if I have to run around the room, just make me run around the room, all right? And I got to get this microphone to you. And by the way, only I hold the mic. There's germs in the air. One germ on the mic.
I actually have 3. Can I ask
right now.
just one? Okay. What are your thoughts on Lemtrada in reference to the bleeding in the lungs?
So Lemtrada is one of the medications we touched on called alemtuzumab is the generic phrase. It is a medication, briefly, that knocks down your entire immune system, your B cells and T cells, and they slowly reconstitute, and we think they reconstitute in a different way. There are lots of risk factors for them, which include additional autoimmune disorders. Most of the bleeding related to Lemtrada has been found to be associated with an autoimmune condition that attacks your platelets, and people's platelets go down, and then your platelets are what form blood clots. And so having your platelets go down have made it increased likelihood of bleeding, including in the brain. And in one of the trials, they was actually stopped because one of the participants in the research trial did actually pass away, and that's how they discovered that side effect. There's more side effects that are still being discovered, and side effects happen with everything. I would answer specifically that alemtuzumab has a lot of very real risks, but it is also a very strong medication for people who need it, but it's not a first-line medication for everybody.
Question here.
Hi, thank you for your presentation. My question is, as a healthcare provider, you said as the neurologist, you should be the spearhead of the full team. But with the insurances, they tend to make the primary the lead. How do we bridge that, or in your perspective, what's the best thing to do to bridge that?
Yeah. And how that's organized will depend on your insurance, and that's okay. So your primary care doctor is the captain of all the teams for everybody who has generic diseases. So if you're a healthy person, your primary care doctor is your captain. Absolutely agree with it. If you have high blood pressure, diabetes, high cholesterol, your primary care doctor is the captain of all of those teams, and I need to work with them very closely. If you have multiple sclerosis, I promise you I am better at caring for that than your primary care doctor. I'm not insulting your primary care doctor. They should admit that too. And so I should take over being the captain of multiple sclerosis. So symptom management of multiple sclerosis, deciding to have you on a medication for spasticity, having you on a medication for walking in multiple sclerosis, called Ampera is the name brand for aminopyridine, which has side effects of potential seizures. So that's also a neurologic disease. That should all be centered by me, but I should be working hand in hand with your primary care doctor, telling you telling that primary care doctor what I think they need. The primary care doctor should be talking to me about your diabetes, your high cholesterol, your blood pressure management, so that we aren't prescribing 2 different medications that are fighting each other, and it needs to be very close. So then you get 2 captains, is my short answer.
Next question here. I got it.
Could you explain, please, what is meant by 30% reduction in disability or 70% reduction in disability? What does that mean? An individual person gets a specific amount, or all the people in the study overall, 6 of them had 100%? I mean, what does it mean?
That's a great question, and the answer is that when it comes to determining how you are going to affect one medication, the evidence that we have is 0. We don't have a way of telling right now what one individual is going to do or how they're going to react to a specific medication. Any of the statistics that we put on the labels and the advertisements for these medications come from a pool of people. So if you take 100 people and give them a placebo, a sugar pill, and you take 100 people and give them this medication, the people receiving the placebo as a group will have 30% more relapses than the people taking the medication as a group. Within that group, there might be some people who have no relapses at all, and some people who have multiple relapses. And what one individual does is affected by what we see on the MRIs, what we see based on your history, and it's very individualized, but we don't have any research that can tell us which one you are exactly, definitively 100%.
Okay, next question.
Does relapse remitting MS always transition to progressive?
No.
Okay, good. Okay.
Shortest answer of the night.
Great. That's the next one. Wow.
Oh, one more. Does high-dose biotin affect your labs?
Yes.
Okay.
It does affect your labs, which is why any of those medications I said today, you should talk to your doctor. Don't go home and start something just because some guy on a stage said it. Please. But it can affect labs. Important ones are your thyroid, so that uses it. And then the other one, important if you're on high-dose biotin and you have chest pain and go to an emergency room, it affects the labs related to your heart called troponin. So that is an important thing to discuss with the emergency room. Those are the kind of the two most common important ones to know about, but there's a list of probably about 20 labs that are affected by biotin, and that information is available out there that you can see which ones it is, and your provider should be able to provide that information to you before you start high-dose biotin.
Question here.
Should Cytoxan be used for any form of multiple sclerosis?
It's a good question. It's a complicated answer. I won't go into all the specific details, but it is not an FDA-approved medication for multiple sclerosis and therefore should not be considered first line. That being said, there is quite a bit of experience among providers of using cyclophosphamide, which is Cytoxan, for multiple sclerosis or other autoimmune disorders affecting the central nervous system. And it is certainly reasonable in certain patients to receive it, and that's an individualized discussion that you need to have with your doctor.
But is it dangerous?
It has side effects like any medication. It's originally a chemotherapy.
I was on Ampera, and I had 3 grand mal seizures because of it. I know that I'm not on that medication anymore. I know I'm going to have epilepsy for the rest of my life. But is there any other seizures that might happen if not being on the epilepsy medication, but if I was still on Ampera and I'm not going to ever be on it again, is there a possibility that I could have more seizures?
That's a complicated question, and I honestly don't know all the answers to it. I'll say that epilepsy is a diagnosis of 2 or more seizures without a known cause, so your seizures on Ampera probably shouldn't be counted towards the diagnosis of epilepsy. You need to talk to your neurologist about whether you're still at higher risk. Likely people who are prone to seizures are more likely to have seizures on Ampera than people who are not prone to have seizures. I don't have the specific data to talk to you about that. That's something you should talk to your neurologist about, but I would say a seizure on Ampera is considered a provoked seizure, which is different than epilepsy.
We have time for 3 more questions, okay? One is here.
My question is, why is constipation attributed with MS? Because I've been having issues with that the last 2 weeks. So how is it effective? I mean, what does it do?
So your voluntary control of your sphincters is all controlled through your brain. And then also the centers for kind of the motility of your gut and things like that are located in your central nervous system as well, so that can all affect it. Oftentimes people with a history of spinal cord lesions will develop the bowel and bladder issues more commonly than people with brain lesions, so it may be involved with some spinal cord issues, but it's also just a common symptom in multiple sclerosis.
Hi. What do you consider normal doses for maybe a person without MS or a person with MS? Should the person with MS have higher doses of vitamin D, or are they losing some vitamin D, or are they not having some? If they take vitamin D supplements, should it be a D3, and is the one more absorbs better than another?
Yeah, great question. And I actually had a sentence on one of my slides, but I didn't touch on it. D3 is typically better absorbed than D2, and on average, people who were deficient in vitamin D, about 3,000 international units of D3 was needed to bring them into the normal range. And so we typically say that somebody taking that we know is deficient should be taking at least 3,000 units of vitamin D. If they don't know and they just happen to take it over the counter, if it's 1,000 or 2,000, yeah, we don't know whether it's helping or hurting. The big thing is that levels can be followed. So if you really have a question about how much somebody should be taking, check a level and see where you're at, and then you'll know.
Before anybody else asks a question, I have one for you just because I like to ask it. Biomarkers. What are you all doing for biomarkers these days?
Not as much as we'd like. So the big one that's making a lot of news in Europe this year is neurofilament light chain, which is a big name. It's a protein associated with the nerves themselves, and when they're damaged, the levels go up. A lot of people are hoping that it can predict future disability or future relapses, that, hey, people who are higher levels of this, maybe they're going to do worse. The people who argue against that are saying, well, anything that damages neurons can cause neurofilament light chain, including aging or stress, and so it won't be specific to, just because yours is high doesn't mean that it's because of your MS. It can be caused because of lots of things, and certainly if it's measured during a relapse, that's probably not predictive of what you're like when you're not in a relapse. So there's still a lot of research that needs to go into it, but that's probably the closest to being something that's used clinically. As far as a biomarker of disease activity, from blood work, and then MRIs are still the best marker of disease activity that we have right now.
Any other questions? Anybody have a question? Wait, one over there. You got one over there? Wait.
What's your opinion on stem cell research?
If you're a part of a approved, qualified trial, then it might be reasonable for individual situations. Briefly, stem cell is not just a buzzword. There's lots of details and variants that goes into that. There's two main types of stem cell research out there. The first is basically getting the same type of treatment that someone with a blood cancer gets, where they try to eliminate a lot of your bone marrow and then give you back your own stem cells to replenish your bone marrow and basically give your whole immune system a reboot. That has been shown in research out of Canada and a couple of trials in the United States to definitely reduce the amount of relapses in very severe MS. But there's also been deaths associated with the treatment. So it's something very serious to think about before you go do it. The other part of stem cell research is not doing any of that chemotherapy, trying to reduce the current immune system, and just giving stem cells. That's going to be targeted at trying to repair. You'll notice I said that your body can repair myelin, but I never talked about any medications that repair or help repair us because we don't have any yet. There's some research hoping to do that, and there's probably some research starting at USC in the next year using that. And so as part of a research trial, that might be worthwhile depending on what your individual situation is. I would not recommend going to these private stem cell clinics that are just advertising miracle cures. We don't have any proof that it is that, or that what they're giving you is anything even remotely close to what will actually work, because these private institutions in other countries are not regulated by the FDA. They haven't proven it to be safe or effective. So I would say if you're going to be doing stem cell therapy, please be part of a registered clinical trial at a respected academic center.
Hi, with Rituxan, what are some of the side effects? Would balding of hair be one?
Yeah, I haven't heard of that. It is essentially it reduces your B cells, which is part of your immune system. It really shouldn't make a big difference in balding. Cyclophosphamide, Cytoxin, the one that you asked about earlier, that will. but rituximab is a little bit different. It doesn't turn over the same type of cells, so hair thinning. But some of the common side effects, any of the infusion medicines that you're getting through an IV cause infusion reactions where you get flushed, you get itchy, hot during it. You can feel kind of sick after that day of receiving the inflammation, but usually after that, it's pretty well tolerated. Rituximab is something we use routinely, and ocrelizumab is its cousin, using routinely. There's maybe a small signal of breast cancer, though we think that's not actually going to pan out over long term, that it's actually going to be safe without it. But if you have, it is on the label of ocrelizumab currently, so if you have that in your family history, it's something to talk to your doctor about.
Okay, so let's all thank the doctor for coming down here today. That's great. Thank you. That was a great talk. Absolutely. Absolutely.